Hello, and welcome to the Advocating for Successful Healthcare Workers Influenza Vaccination Program webinar. Today's program explores novel and evidence-based strategies for maximizing employee participation in medical center influenza vaccination programs. This program is being recorded. There is 1 hour of CME and MOC credit for this program. You received a verification form with today's instructions, or you can follow the link that was in those instructions. No certificates will be sent to you, but your transcripts of this and other ACOEM educational programs can be viewed and printed from the ACOEM website. Members and non-members can both view their transcripts directly from the website. Today's program will consist of approximately 45 minutes of lecture and questions at the end. We will address questions as time permits and suggest you submit your questions early for consideration. We are only accepting questions electronically. On the screen, you can see how to open the question box in order to submit those questions. This was also in the PDF file of your handouts you received with your instructions. We are very fortunate to have as presenters today Dr. William Flulike, who is Medical Director of the Employee Occupational Health Service at the Mayo Clinic, where he also serves as Section Chair of the Occupational Medical Program, as it is an instructor at the Mayo School of Medicine. And Dr. Melanie Swift is a Medical Director of the Occupational Health Clinic for Vanderbilt University, where she is also Assistant Professor of Medicine at Vanderbilt Medical School. On behalf of the faculty and planning members, we would like to announce that there are no disclosures to be made. So it is my pleasure to turn the program over to Dr. Melanie Swift. Dr. Swift, you may begin.
Good morning and good afternoon to those of you on the East Coast. I'm sure we are all deep into the midst of our own flu vaccine programs. So I hope that this can stimulate some new ideas that, if they're not too late for this season, will help you out for next season. Our objectives today are to, first of all, understand the benefits of a flu vaccine program for healthcare workers, both the proven benefits as well as some theoretical benefits, and talk about a little bit about the evidence behind that. We will discuss the elements of a robust program, address the utility of declination forms, and discuss some strategies to improve your participation rates, focusing not only on what does work, but on what may not work and you need to watch out for. So first of all, just the rationale for flu vaccine. I'm probably preaching to the choir here, but I just want to cover some basics. One presumption is that influenza is common, and the figure that's quoted is 5 to 20% of the general public gets infected annually. And there's some nuances behind that. It may be a little less common in adults. The vaccine is moderately effective. In most years, we have a good match. About 8 out of 10 years, we have a good match. And in those years, the flu vaccine effectiveness is in the 70 to 90% range. There are those years that we have a poor match, and in those years it's, of course, much less effective, but still not zero. There's good evidence that vaccination of healthy workers, including healthcare workers, reduces the incidence of influenza illness and reduces their sick time that's taken. The vaccine itself is quite low risk, and it can be cost-effective. The cost-effectiveness depends upon how you set up your program, so I'll discuss some elements of the program that can make it more or less cost-effective. First of all, the presumption is that influenza is common. Certainly, this year we're seeing a novel situation. We'll discuss H1N1 a little bit at the very end of this presentation. But for seasonal influenza, you can see on this slide the studies that have assessed or attempted to measure the annual incidence of influenza. You can see from the 1918 pandemic year, the rate in adults of influenza-like illness was up to 1/3 of the population. Most of the data from which our 5 to 20% estimate derives is from a cohort study of one town in Minnesota that was followed actively from the 1970s to early 80s, and the range was measured for people under 20 and people over 20. For people who were under 20 years old, you saw the higher rates of incidence, that 12 to 20% range. Usually the rates for adults over 20 was about half the rate of that in children. I found this very interesting because in the 90s, these are the only studies that really are published to tell us what the rate of laboratory confirmed influenza is for a cohort that's being actively followed and surveilled, and the rate in adults is around that 5% mark. The side effects of the flu vaccine are quite mild. There's a lot of coincidental upper respiratory infections, of course. We've all heard that story. I got my flu shot and then I got sick the next day. But there's a very nice study in 1996 that compared placebo injections to seasonal influenza vaccine, and this is the trivalent inactivated vaccine. And there were no statistical differences in the incidence of side effects except for a sore arm. And we do expect that to happen, and it generally lasts 2 days or less. Now on this slide, there's some interesting studies looking at the cost effectiveness of flu vaccine for employees. And there are different designs, but it's interesting to see the variability in the return on investment for flu vaccine programs. So I was curious about this. And the Nichols study and the Campbell study were randomized controlled trials where some employees were given seasonal flu vaccine and others were given either a different vaccine such as pneumococcus or placebo. And they showed that you saved from $22 to $46 per employee vaccinated. The Bridges study is an observational study in a manufacturing plant, and that was over 2 different years, so you see 2 different numbers. And they actually lost money. So Nickel, that's actually the same Nickel that did the 1995 study, did a modeling study where she was able to do, through computer modeling, to input lots of different variables that impact how cost-effective the flu vaccine actually is. These variables include things like how common is influenza infection that season, and that's going to vary dramatically from year to year depending on how bad the flu is that year. How effective is the vaccine, and as we've discussed, that's going to vary from year to year. The cost of the vaccine doesn't vary that much, but the wage of the worker is also a very important variable. And based upon all of these different variables, this author determined that the average was a $13.66 savings per employee vaccinated. But as you see, there's a range, and the best case scenario could be up to $33, and the worst case scenario could actually end up with a net loss of a couple dollars per person vaccinated. So if there are things that make the vaccine program more cost-effective and less cost-effective, can you control any of that? Well, some things are clearly uncontrollable. You can't control what the incidence of flu is that year. You can't control what the vaccine match and effectiveness are. However, there are factors that you can control. A lot of this has to do with the non-productive time of the employee that it takes them to get the vaccine. So there's nursing time to deliver the vaccine. That's weighed in on the cost side. But there's also the employee time to obtain the vaccine. And this turns out to be very, very wage sensitive. So think of it this way. If your vaccine costs you about $10 to buy the vaccine, then you buy supplies, you track and you monitor the program, you have a nurse to administer it. Let's say on average it costs you $25 to give an employee a flu shot. That's pretty much a fixed cost from employee to employee to employee. But the other piece of that cost is the amount of time that it takes the employee to come over, sign in, fill out forms, get their vaccine, and go back to their place of business. In the Nichols study, that was the single most important variable that you can have control over that impacts the cost effectiveness of your flu vaccine. If you increase the time that it takes the employee to get their flu vaccine to 2 hours, then you actually negate the cost effectiveness of the flu vaccine program. This is also extremely wage sensitive. So in healthcare, if you are vaccinating, say, nurses, and the average wage, just to make it easy math, I'll say is $25 an hour, then for every hour that it takes the nurse to come over and get the vaccine, that's $25 that's added to the cost of giving them that vaccine. You've just doubled the cost of the vaccination for each employee. So it's very, very important as you structure your program that you're sensitive not so much to how long it takes you to deliver the vaccine, although that is important, but how long does it take the employee to receive the vaccine, and what is that employee's wage? Other things that can add costs, any unnecessary costs to the program, and then looking at incentives and whether they are effective or not effective. Incentives are a very popular thing to do. I've heard of one hospital giving people $20 bills to get their flu vaccine. Just bear in mind that each incentive, the cost of that adds to the cost side and does not make the vaccine more effective. Although it can, if your incentive actually increases your vaccination rates, then you could accrue some additional benefit from that. So speaking of benefits, who actually benefits from your flu vaccine program? Well, we've discussed that flu vaccine can benefit your workers by keeping them healthy, keeping them from using sick time. And obviously you want healthcare workers to be well and at work and present during flu season because you need someone to take care of the patients that you anticipate. But does vaccinating healthcare workers actually benefit others? This is an area where there has been tremendous discussion with really very scant evidence. Theoretically, this does make a lot of sense. There are outbreaks of flu that have happened in hospitals. Usually the source of that outbreak is unknown. In most of the studies, they're really not able to determine if the patient was infected by a visitor, another patient, a family member, or a healthcare worker. Theoretically, we know that people do shed the virus before they know that they're sick, and that healthcare workers, unfortunately, have that work ethic where we come into work even when we're not feeling well, and that we're not perfect in practicing infection control, although I do think that that's improving with added education. And we know that we have a vaccine that's usually moderately to highly effective. So when this is put to the test, it's actually put to test in the nursing home setting. We have 3 studies of providing influenza vaccine to healthcare workers and looking at the impact on their patients. All 3 of these studies were in a long-term care setting. One of them, the second study, the Potter study, included patient vaccination as part of the program. These were all voluntary, and they achieved vaccination rates from 43 to 61%. So these are not skyrocketing vaccination rates, but they're pretty much what we're seeing across the board in the U.S. on average. In the first study, there was a non-significant reduction in mortality. In the second study, there was reported a statistically significant reduction in overall mortality of the patients. Interestingly, this only held true in the homes where the patients were also receiving vaccine. The third study was a 2-year study, and it demonstrated the benefit in the first year, but not in the second year. There's one study that looks at an acute care hospital setting, and this is an observational study, The interventions were multiple. They had healthcare worker vaccination, patient vaccination, active surveillance for nosocomial infection, screening and isolation procedures for patients, and a massive education campaign. What they observed was that over the course of 12 years, their healthcare worker vaccination rate increased significantly. And they saw a decline in cases of nosocomial influenza. Of course, it's obviously very difficult to tease out any one intervention as responsible solely for that improvement. The Cochrane Collaboration, which conducts systematic reviews of evidence on various topics, did review this topic in 2006. The author's conclusions were that there's really no credible evidence that vaccination of the healthcare workers who are taking care of the elderly actually affects influenza complications in those cared for, but given that vaccine can help keep your workers healthy and vaccinating the patients themselves is a good idea, it's a good idea to have a program. How do you translate this from the nursing home setting into hospitals and clinics gets a little more difficult to determine based on any evidence. The risk of the transmission from the healthcare worker to a patient really depends upon the amount of contact that that person has with their healthcare worker, and are they also having contact with lots of other people. Also, we need to consider how much of the flu season this person spends in that setting. In the nursing home setting, these are residential patients, and they are in that setting for the entirety of the flu season. In the acute care hospital, we have a very different scenario where patients are admitted, they leave, they're admitted, they leave, they're spending a lot of time in the community throughout the flu season as well. So that's going to dilute the impact we would expect. In the highest risk setting, we do see some benefit in some years for having voluntary programs that achieve modest vaccination rates. It's still really unknown what the impact would be in the acute care setting on patient outcomes and whether higher rates would mean greater impact. There really are three essentials to your flu prevention program that cannot all rest on the vaccine because, as we've seen, vaccine is highly variable in its effectiveness, and there are other measures that can help prevent transmission, not only of flu, but of other influenza-like illnesses to patients. So education should cover the basics about transmission of influenza-like illnesses, should educate all the employees on how to get vaccine, should reinforce hand hygiene and respiratory etiquette, the importance of PPE, and education really should be tracked and enforced. And, you know, we have a lot of emphasis on tracking our vaccination rate, and I really think we need to put more emphasis on tracking and monitoring our education rates as well. Infection control practices have been proven to be very effective at interrupting transmission, so we really need to monitor and enforce that. Hand hygiene, incredibly important. Patient screening. Actually, I was at a conference and heard a speaker from Denver Children's Hospital, and they are implementing through the flu season a policy of not allowing visitors under the age of 12, just because they tend to be vectors of germs. And also housekeeping practices. Influenza virus can live on a steel or plastic surface for 24 to 48 hours. So it's really important to continually have a program of keeping those surfaces wiped. What you measure in your program, I think, is very important. We have a lot of processes that we're able to measure: the vaccination rate, hand washing compliance, education rates, and what people are calling compliance, which may mean that they've declined a vaccine. But all of these processes are intended to drive an outcome that we care about: reduction in sick time, reducing healthcare costs, preventing cases of nosocomial flu. So I like to challenge people, if they're wanting a measure, that you really look at including one of these outcome measures as well, especially if you're considering mandating flu vaccine, as a lot of places around the country are starting to do. I think it's very important that we not get distracted by that conversation and keep our eye on the ball, and are we really impacting the things that we care about. So The ACOEM guidance document, which is available on the ACOEM website for seasonal vaccine of healthcare workers, lists the following elements of a robust program. And it emphasizes staff education as the starting point. Influenza vaccine, of course, remains the cornerstone. And obtaining employee feedback, we think, is very, very important. If you're not listening to the employees, you really cannot have a meaningful dialogue. There are innovative and non-punitive and anonymous ways to obtain employee feedback and to get candid feedback that you can really use to make some meaningful adjustments to your program. Providing the vaccine in very innovative ways is a way that many places have kept the tone positive and increased their vaccine rates. Some of these pictures here are to depict different ideas. A lollipop, one hospital had a lick the flu program. They handed out lollipops. I found that a little bit concerning. I don't want to lick anything with flu on it. The duckies, there was a great little story of one hospital that had a donation of these rubber ducks. They gave a duck to every person who got a flu vaccine, and then they posted photographs that people took of their duck going to different places over the holidays. The CNO's duck got held for ransom, and it was a great interest and enthusiasm builders. Kiss a pig, where you have an administrator kiss a pig if you achieve a certain rate. I'm not so sure with swine flu we want to promote that one, but I thought I'd include it. Shot for a shot, where people have gotten coffee vouchers for getting there as an incentive for getting flu vaccine. Innovative delivery systems. In the center is a photograph from a hospital in Boston that is actually doing drive-by immunizations. On the bottom right is our program where we put up a tent that what you can't tell is this is right next to the shuttle pickup spot. So at change of shift times, there are huge lines of people waiting to as they come in and out. And that's a great opportunity. It's really hard to navigate around without passing by this tent, so it's incredibly convenient. And we've clocked it at about 90 seconds that it takes someone to get their flu shot at this tent. We also have a little promotion called the flu jail, where we throw some leaders in jail, and they have to get bailed out by convincing people to get their flu shot. The other elements of a robust program include monitoring and enforcing those infection control practices. Leadership is very key. Leadership stands out as one of the things that can really, at no cost, increase your success of the program tremendously. Do your leaders establish goals? What is your goal for the employee education and vaccination program? And are there goals for vaccinating patients, and are those also being monitored? And as discussed earlier, I recommend that you monitor not only your vaccination rates for patients and employees and your education rates, but your nosocomial flu infection rates as well. And with that, I'm turning it over to Dr. Buchter.
Thanks, Melanie. Really enjoyed that. I learned some things out of that.
Thank
Great. Well, I'm going to focus on one leg of our three-legged stool that is referenced in our guidance document, and Melanie pointed out in the slide previously. Get away from education and infection control, get back to the vaccination issue. And if you'll humor me a little bit with a little humor, or abide by a little humor, there are good ways and bad ways and potentially ugly ways of going about upping your vaccine compliance. And I think it really depends on what your goals are, what your objectives are in your institution, and what your motives are, and what your perceived motives will be by your employees and possibly by the community and by the patients for that matter. So these are different ways of looking at a vaccination strategy. And I'll go through each one of these as a separate slide. So moving along here. I think a good way is to have a culture of caring. Do you really care about your employees? Do you promote it as an employee benefit, that this is something we're doing for you? We're not going to take it out if you don't have to pay a copay, co-insurance. We're paying for this. At the same time, being honest about the fact that this is a good business deal. As Melanie pointed out, in most years, this can be justified as a good business or to decrease business expenses. It can decrease healthcare costs, and that might actually decrease the premiums for the employees. And it might help people save their PTO for vacations rather than taking a week of being sick with the flu. It also helps with by having fewer workers sick with the flu, especially during peak times. It will help eliminate staffing problems. And that helps everyone, not just the corporation, but also the coworkers that would have to pick up those extra shifts otherwise. And probably the most important one on here is the visible leadership participation or promotion. And I can't stress this enough. You're not going to get a successful program if your top leadership and the key people within your organization are not endorsing this, either through emails, through personal participation, taking a picture of your CEO getting his or her vaccination and putting that on posters, whatever it takes. Some organizations, take Barnes Jewish in St. Louis with 25,000 employees. 2 years ago, they made leadership incentives by scorecard performance based on flu vaccination. So you can bet that the leaders, their pay was dependent upon how well they did. And they boosted their numbers from about 54% up to 71% that same year. Unfortunately, they went to a mandatory program last year, as many of us know, and we really question whether or not that may have been premature, but I'm getting ahead of myself there. Another program was St. Jude Hospital in Memphis. 2006, they had, with a voluntary program, they had a 96% participation, which was largely due to leadership support, but a whole host of other programs and being very persistent about reminding people so that they made it an active decision whether or not to get the vaccine, not a passive decision. And then, of course, there's the appropriate rewards, and I think Melanie outlined some of those very well. I think at University of Connecticut, it's real interesting. They found out that with the cup for a cup, or a shot for a shot, and it was coffee, not other beverage, was very effective in bringing in the people that did not provide direct patient care, but it didn't seem to affect the people that provided direct patient care. Those people apparently, even though they got an additional reward, said they would have come to get their vaccine anyway. So it kind of depends on which population you're targeting as well, and whether you're willing to invest in those incentives. But that's a culture of caring, developing teamwork, and doing this together. Slides here. Another one, and this is in the same vein, is making the health promotion goal. Promoting health for the worker, for their family, friends, coworkers, and if possible, providing the vaccine to families if there's adequate supplies, and if the employer is willing to buy into that. That's not a bad strategy. And then, of course, for patients. And we're all professionals. Our goal is to do no harm. Now, I think we harken back to Himmelweiss in the 1880s and him confronting his colleagues that were going from the autopsy suite to the delivery suite and couldn't figure out why women were getting puerperal fever. I got a question. I mean, are we doing those kind of things today? As Melanie pointed out, I don't think there's a lot of support for that kind of a fear that healthcare workers are actually intentionally infecting or unintentionally infecting their patients. We'll talk more about that later, but there really isn't much proof that the healthcare worker is spreading flu to their patients, at least in an acute care setting. The other thing I just mentioned real briefly, and there are some references at the end of your list of references about this vaunted 36,000 deaths per year that keeps being quoted, which came from one source, and that was in JAMA in 2003, based on influenza-like illness. And there are two other references that if you boil that down to influenza, the estimates are actually more like 6,000, 14,000, or about 10,000 per year. That's a much smaller number. It's still large, but I think we need to talk about real numbers here, not fantasy numbers. Well, the next issue is what really works here. Well, there are a lot of variables, and this is what's really important, is it's not a one-size-fits-all issue, that you can't say this is going to work in Connecticut because it worked in California. It depends on the size of your hospital, it depends on your community, where you are, the culture of that organization. Is it a for-profit or not for-profit? I think all those things factor into it. Do your leaders support the program? Your patient population. At St. Jude, even though they had a 96% participation rate, The NFID does report that they are planning to go to a mandatory program, and maybe have this year, because of the nature of the pediatric cancer patients that they cater to. And there may be some justification for that. Whether they needed to boost from 96 up to 100, whether that was justified, I can't say, but that was their decision. Also, it depends on the viral match. How well does the vaccine match with the virus that's circulating? And bad year, when there's a mismatch, or when the virus is relatively mild, it's very hard to advocate for a flu vaccination program, such as last year when the flu seemed to come very late and then morphed into another flu, of course. But it's hard to advocate for something when there's not a little fear involved. And of course, we know that education works. We've proven that here and other places. And then the innovative practices. There's peer vaccine, going out and giving the vaccine to a nurse in the ICU and having that nurse vaccinate peers in the ICU. That can be an effective program. Or having what we call bus stops, that the traveling nurses will show up at a certain time in a certain location, and employees are well aware of that in advance, and it's a time that's convenient for them. And then something we call the enhanced flu vaccine program, in which we target high-risk units such as bone marrow, pediatric ICU, and we really have emphasis on reminders to that group throughout the flu season, and actually collect data month to month and report back to the supervisors what percentage they've reached for their unit, and encourage competition between units. Of course, leadership support's important, and let me just give you this slide's a little busy, and it bears some explanation, but this has been our experience at Mayo. And I just mentioned back 1994, which is just a year that I had data for, is that there was about a 50% match between the vaccine effectiveness at that year, and but that's consecutive starting in 1999. And so there's the characteristics column kind of describing the flu vaccine and the flu that year, and it would be 2000 to 2001. The first number is the beginning of the season. And then our compliance rate with the vaccination. And then that last column is kind of a combination of the rates we got once we started our enhanced program, targeting those high-risk units, but also some of the things we added to our program in previous years. So starting in 1999, we had a 53% compliance. And then there were shortages. A lot of people don't remember this, 2000, 2001, in the supply of vaccine. There aren't many manufacturers of this vaccine, and one quality control issue can significantly limit the amount. We had barely more than 40% participation, but it wasn't just because people didn't want it, it wasn't available. In 2001, we started the peer vaccine program, and the next year we did get up to 56%. That was a pretty average year. We added incentives that year as well. And then next year, there was only a 45% match between the vaccine and the circulating viruses. The H3N2 was not terribly well matched. But we had a 76% participation rate because we had added education to the incentives in our peer vaccine. That was kind of our hallmark year. As many of you remember, 2004 was the disaster year. We had a severe shortage. We had to prioritize vaccine. We had to turn people away and say, you cannot get the vaccine this year. And there was only a 62% match between the circulating strains, I think largely because I believe it was that year, the influenza B, we had no vaccine effectiveness at all, and partial for one of the circulating A's. But that same year, we started an initial enhanced program, and in those high-risk groups, we got 76% compliance, which we thought was pretty good. So in subsequent years, you can see we've been able to hold around 80% on the enhanced program, and been able to gradually boost all of our employees, which includes administrative as well as healthcare related, up to about 80%, and we've been pretty happy with that. So here's my issue. We've gone from good to what may be kind of bad, and that's when this graphic didn't work out too well, but this is a picture from when we had the avian flu. But we should be afraid of the flu. And our patients shouldn't be afraid of healthcare workers who might be carrying the flu. That is this concept of healthcare workers a vector of disease. And we really question whether that's the kind of attitude we want to have. This is really a tenet of infection control. This is not an occupational medicine thing. And I can understand how infection control people would want to eliminate anything that might possibly increase the infection rates in the hospital, but we need to question whether this is really a valid tenet. It presumes there's inadequacies of our standard precautions, hand washing being number one, that our personal protective equipment doesn't work, and that our sick leave policies aren't effective. And it insinuates that there is airborne transmission for flu, and there is some justification for that in certain settings. Just not so sure if the virulence of airborne flu, and that is yet to be seen. It insinuates silent shedding, and we know that that does happen, that people can be shedding the virus for up to 24 hours before they become symptomatic. And it implies that our healthcare workers are simply careless or, in fact, malicious. And I'm not sure that's the attitude we want to take. So one approach that's been taken, and I'm sure some of you that are on the call have used this, and that's the declination statements. I'm not going to say that they're bad, but I think you have to ask the question, who's benefiting from this declination form? Are you doing it just to boost the numbers, or to say that you did something, or to report compliance with a policy? Or are you actually trying to influence the behavior of your employees, which obviously should be the goal here? You want to be able to educate your people during the process, but don't make it a guilt trip. And is this really a displacement of liability from the employer to the employee? That's yet to be seen. But again, I don't think employers will perceive that as a positive move. And then there's the issue of variable effectiveness of declination statements. I know at the VA system and at Marshfield Clinic, they have not found declination statements to actually boost their vaccine compliance. We did a continuous improvement project here at Mayo about 3 years ago, and we found the same effect. That in a controlled setting, there was no benefit from declination statements. In fact, there was probably a slightly negative impact on likelihood of compliance, and they were frankly not very happy about being asked to sign such a statement. And then there's the questions, are patients safer just because a healthcare worker signed a declination? I think we all know the answer to that. And then there's the administrative hassle. The year before Barnes-Jewish made their program mandatory, 13% of their 25,000 employees didn't do either, sign the declination or get the vaccine. How do you track down those 13%? I don't know. I don't want to be the one doing that. And having a declination statement can be useful for doing a survey. If you include a survey in the declination as to why you declined it, that will satisfy the Joint Commission requirements for program assessment. So there can be some positive things that would come out of use of a declination. Again, you have to ask, why are you doing it? So the next, of course, is the ugly. I just couldn't find a better picture for this. But this is becoming the wave, or you can call it a tsunami if you like, is mandatory vaccination. I think a lot of us know that New York State has mandated it during an emergency dictum last month, and I think most of us know about the Virginia Mason experience over the last 3-4 years, Barnes-Jewish last year, and now there are quite a few others that are going that route. So I'd like to look at this issue of mandatory from a couple of perspectives. First one is the historical perspective. Let's look at our graph again. Mismatches, shortages, delays in delivery of the vaccine. That actually predominates from year to year over the last 9-10 years. The question is, can you mandate something that may not even be available, and something that didn't work in about half the time in certain subset of the population? It's very difficult to mandate something like that. This is just something that I think is, I was at a conference in Cape Town, South Africa in March, and talked to the people down there about mandatory vaccination, and they were aghast that we would think of such a thing in this country. As you can see from this WHO graph, that the rest of the world is starting to wake up that this vaccine is out there. As the rest of the world gets a little more wealthy, they're starting to use the vaccine. This is more on a percentage scale. This is very enlightening that there are about 350 million doses available worldwide. Guess who's catching up? The rest of the world. So traditionally, about 10% of the world's population, North America and Western Europe, use 50% of the vaccine. If the rest of the world caught up even by 5%, the vaccine supply would be incredibly challenged. And that's largely because of the nature of this vaccine and how labor-intensive it is to create and how long it takes to actually get the production going and how few producers there are. So how can you mandate something that could very likely become a shortage in the very near future? And then there are ethical considerations. I'll leave this to your imagination largely, but you can imagine that when you violate someone's arm with a needle and inject something in them, that is a personal health choice. And what we're talking about is employers mandating how people govern their own health. The question is it effective? As we've already seen, it's quite variable, this vaccine, compared to other vaccines. And the non-maleficence, there can be a false reassurance. For instance, my employer said, I have to get vaccinated. I got vaccinated. I now feel like I have the flu. I can't have the flu because they made me get the vaccine. Obviously, that can be a false reassurance. Necessity, we've shown that you can get at least 80% compliance with a voluntary program. And then there's the issue of honesty and transparency. Even though your intentions might be good for the patient and for your employee, anytime you make a program mandatory, the motives are perceived differently by the employee. And then there's also the issue of the biggest proponents of mandatory programs tend to be conflicted by associations with the drug companies. I'll leave it at that. There are potential legal issues that by having someone, first of all, there's no federal mandate for mandatory flu vaccination. New York is the very first state to try this. There's likely to be a challenge to that. There's no accreditation mandate. Joint Commission did not require mandatory. They considered it, but they did not put that in their accreditation policy. There's potential HIPAA violation. If you either have to get the vaccine or wear a lanyard, as some people are saying, that shows that you're not vaccinated, or wear a badge or not have a badge that says you were vaccinated, that is essentially wearing your protected health information on your sleeve or around your neck or on your face, as we'll talk later. And there have been legal challenges. The Canadian paramedics challenged this in the 1990s and won. The nurses at Virginia Mason won their lawsuit, but unfortunately lost an arbitration that said that they had to wear face masks as an alternative. And it goes on and on. And then there are the practical issues. That people that get vaccinated under a mandatory program are likely, possibly, to become more complacent about the infection control policies. And what this does is it detracts resources from the other two legs of the stool, of education and infection control. And it also makes incentives relatively meaningless. I think some places are still doing it with their mandatory programs, but I doubt that the employers are seeing that as having any kind of a warm, fuzzy effect. Also, the evidence of efficacy. Melanie learned this herself, that at Virginia Mason, the year before they started a mandatory program, they had no nosocomial cases of influenza. The year after they started a mandatory program, they had one. So, again, where's the money here? Where's the evidence? And at Barnes-Jewish, they had exclusions for religious and medical reasons. They had those people wear masks throughout the season. But they also had exclusion for non-employed providers. Most of the physicians are not employees. There was no way to mandate it for them. So the question is, if unvaccinated healthcare workers are such high-risk vectors, what are the consequences of noncompliance? Well, you could reassign them to non-healthcare jobs, which certainly isn't very palatable. Or you could terminate them. Barnes-Jewish terminated 8 people last year. Virginia Mason terminated 7 when they started their program. I mean, is this commensurate with the crime? And what's next? What else will they mandate and terminate people for? And then this issue of wearing a mask. I'm moving ahead here because we're running out of time. we can debate this till we're blue in the face, but you have to ask about the equity question. Someone is exempted because of a legitimate egg allergy. They can't wear it, but they have to wear a mask, just like all the people that refuse to get the vaccine. How do they feel when they're cast into the same mold? Again, by wearing this mask, you're essentially telling everyone around you, I didn't get the vaccine. I think, and I know there have been some reports from employees to their administration that they think that their HIPAA rights have been violated. That's yet to be seen. Then there's the efficacy of wearing face masks. There's a report to the ACOEM, as many of us know about, last August, and Dr. Lisa Brousseau also reported to them about surgical mask performance over the historically. And there are many studies that cast doubt on the effectiveness of surgical masks from causing nosocomial surgical wound infections, and that needs to be investigated. So it may be just a red badge of called the scarlet letter, so to speak. And then when people are wearing masks, there are communication issues, there are comfort issues, and the question is, will there be enough surgical masks to go around? So the question is mandatory all bad? Well, no. Mandatory education is fine. It's encouraged to be persuasive and to really get the message out to your employees. You can have mandatory hand washing and cough etiquette. You want to have hand washing police? You're within your rights to do that. That's behavior. That can be controlled. Mandatory compliance with your illness policy. Is it generous enough for people to take time off? Is it enforced well by supervisors? And this is a big one, mandatory application of visitor policies. Really, who is the vector here? I'm not going to belabor that one. So these are questions to ask yourself. What's your culture? What have you tried so far? Does your leadership support your policy? Are they clear? Are they comprehensive? And how much goodwill, how many trump cards are you willing to give up if you start a mandatory program and take one more thing away from your employees? And then how effective are the other two legs of the influenza prevention stool? So with that, I guess this is time for questions for us. And Melanie's been screening those.
Huh?
Is that right? You've been screening questions?
Yes. Am I on? Can you hear me?
Yes.
Okay. So we have several questions, and I think I'll start at the top. What level of vaccination do you need for herd immunity to develop? Do you want to take that, Bill?
I will. I'll take that. I have an article right here. It came out of Seattle. It's not a peer-reviewed article, but it does come from researchers in the VIDI, the Vaccine Infectious Disease Institute, Fred Hutchinson Cancer Research Center, September 10th, just this month, alleging that, and these are epidemiologists talking, that if you target children and get 70% of the population, it would mitigate a pandemic influenza outbreak and slow it down significantly. I think the thing you have to understand is herd immunity really applies to a pandemic. It doesn't have much effect during a seasonal influenza year. And I think the large reason for that is we all belong to multiple herds. Let's face it. You have your herd at work, you have your herd at home, church, at the school, whatever. This only works on a large population level. So I don't think herd immunity is really a very good argument in a hospital setting, except in a pandemic year.
If I could jump in really quick, Dr. Swift, and cover the MOC CME questions so that we've got that requirement taken care of.
Sure.
Dr. Butka, can you please comment? And at this time, too, we want to make sure that attendees have the opportunity. Please do submit your questions. We have about 10 minutes remaining to address as many of those as possible. The first question is, 10% of the world population uses 50% of the world's supply of vaccine. Is that true or false?
Do the do. No. That is true. That's been traditionally the case, but unfortunately that number, as I mentioned, is changing. And it won't take much for Asia and Africa if they start using this vaccine to deplete our supply unless we come up with new technology.
Okay, number 2, true or false? During a year with a good match of vaccine to virus, vaccine efficacy is 70 to 90%. Is that true or false?
That is true. During a good year with a good match. But I will reference the ACIP Advisory Council section for
immunization practices.
Patient practices of the CDC. Their 2009 very large document that they actually say that usually there is not a very good match. We have 3 strains we're talking about. There's a lot of drift going on, and from year to year, most years have some drift, and that's what we have to deal with.
Okay, and finally, an effective flu prevention program involves A, education, B, infection control measures, C, vaccination, or D, all of the above.
I think we all know it's all of the above, that we have to focus on all the tools we have available, and if we focus on one of those tools, we're not likely to be as effective.
Okay, thank you very much. Okay, Dr. Swift, you have time to address some questions.
Yeah, we have a couple of questions that are very similar, so I think I'll combine them. There's a question about just our opinion on the safety of the flu vaccine, and a follow-up question that goes along with this. If someone develops a flu-like illness after receiving both H1N1 and seasonal flu vaccine, what are the implications? And is the employee managed the same way? So the safety of the vaccine I addressed on an earlier slide. Really in placebo-controlled, double-blinded, randomized controlled trials, the only increased incidence of side effect or adverse effect of the flu vaccine is a sore arm. Now that being said, there are lots and lots of anecdotal stories that some people, every time they get an immunization, they have a funny feeling for a few days. Their immune system is, active and responding, and they can sense that or something like that. But statistically, there's really no measurable harm from the vaccine other than injection site soreness. If someone gets a flu-like illness after receiving both vaccines or either vaccine, so a couple of issues on that. The seasonal flu vaccine and the H1N1 vaccine are both available in both an inactivated injectable form and a live attenuated nasal spray form. And the live attenuated nasal spray vaccine can cause an upper respiratory mild infection, which is more of a cold. These are cold-adapted viruses. They do not thrive at the body temperature in the lower respiratory tract, so they cannot cause influenza, and they cannot cause pneumonia or a bronchial or lung infection. But they can cause rhinorrhea and congestion and postnasal drip, which can cause a sore throat. And that tends to be mild, tends to not come with a fever, and to last for just a couple of days. So that's really not a flu-like illness. Bear in mind that all the vaccines require a couple of weeks for you to develop immunity. So it's always possible that someone is exposed to either influenza or another influenza-like illness prior to getting their vaccination. And if they get vaccinated, very quickly fall ill with influenza or an influenza-like illness, that's something they were incubating at the time of the vaccine. I think the question might have to do with whether you treat that person any differently. You need to avoid co-administration of Tamiflu and other antivirals, preferably for 2 weeks following the live attenuated nasal spray vaccine, because of course you want that mild superficial nasal infection to actually happen so that you get the immune response and the effectiveness of the nasal spray vaccine.
Very good. I will comment that we started our program last week and given out thousands of doses, and we've seen 2 cases of cellulitis, but you can have that from any injection.
Yeah, we've seen some vigorous immune reactions, but no cellulitis. So, yeah, I think it's sort of that would be one of those very rare sporadic things. Another question: can you co-administer H1N1 and seasonal vaccine? Yes, you can. However, as I mentioned earlier, there's the nasal spray live attenuated form of both vaccines, and those two cannot be co-administered. If you're giving both live attenuated nasal spray vaccines, they need to be separated by at least 2 weeks. You can give the injectable inactivated of either vaccine either at the same time as or with any difference in time between the other vaccine. Let's see if we have any other questions.
You know, I would add one other thing about the question about why older folks seem to be protected from H1N1. And they found that people that were vaccinated for the swine flu in '76, that over 50% have circulating antibodies to that that do coincide with the current virus. So probably we've seen it before. Those of us that are old enough.
We haven't touched on H1N1. Bill, would you like to go to that bonus page and just do a quick H1N1
Sure.
update?
Just real quickly on the Canadian controversy, there's unpublished data that people that were vaccinated last year are twice as likely to get H1N1 this year. Mel and I had a little discussion about why we think that is. It's probably based on selection bias. They're investigating it, but pretty much all of Canada is held off on giving seasonal influenza until after the H1N1 vaccine. That's their choice. Most of us are not following suit on that.
And when you think about it, the people that we're seeing currently in our campaign that are really anxious to get the seasonal vaccine, they're anxious to get it because they're actually at risk of being exposed to H1N1. And so I think, you know, probably you're just selecting people that want to get vaccine, and of course they're also more highly exposed. But I find it really surprising that they're enacting public policy without having the peer review process of that trial go through yet.
So we're not recommending that. The other one is that one vaccine, one dose should be adequate for the adult population. There's split dosing for children, but for the working population, one should be enough, and they should be developing immunity within 10 days. And then this is where herd immunity come into effect. If we get enough people vaccinated, we may be able to slow this thing down. And as Michael Hodgson points out, our goal here is not to stop this virus, but to flatten the curve, so to speak, so we don't get such a huge peak that our country is paralyzed. And that's the public health initiative.
We do have another question that's come in. If someone experiences influenza-like illness or is diagnosed with H1N1 now, should they get the H1N1 vaccine when available, or are they considered immune secondary to their illness? And that's a great question. It's become more interesting now that we are no longer routinely testing everyone. Back when H1N1 first hit back in May, most places were, rather aggressively testing everyone with influenza-like illness and have laboratory documentation now of whether they had H1N1 or not. The traditional wisdom is that if you've had influenza, you should still get your seasonal influenza vaccine, because even though you may have natural immunity to that one strain, there are other circulating strains that you could benefit from the vaccine. That's a little bit different with a monovalent vaccine. Probably if someone definitely had H1N1 influenza, there's no theoretical additional benefit to them of having H1N1 vaccine. However, most people don't have documentation of what they had, so it wouldn't hurt them to go ahead and get the H1N1 vaccine. We're encouraging everyone to get it.
We're asking people that had known laboratory confirmed H1N1 to defer this year, but only those.
Okay. And I think that's all of our questions for now, and we're right on time.
And there's the curve we're looking at. We haven't seen the peak yet.
Okay.
Well, at this point, I'd like to thank all of you for your attendance and thank our presenters for their valuable presentations. This concludes today's program. You may disconnect.